Good afternoon. This is Dr. Thomas Klein. I am a practicing physician in Raleigh, North Carolina. My specialty is long-term illness, and my current interest is in people with chronic and rare painful diseases that are basically lifelong. These are diseases that are not treatable. These are diseases you can only improve symptoms, so we call that palliative care. Palliative care is exempted by the CDC guidelines and most all state guidelines from limits on the dose. As you know, limits on the dose are not proper anyway, any more so than limits on insulin dosage. These are drugs that the FDA has chosen not to put limits on. That's unusual. They have limits on most all the drugs, so it's easy to think, why isn't there a limit? But there isn't. We have people on 2,000–3,000 milligrams a day when the CDC thinks 90 is too much. So we'll leave that aside because we talk about that a lot. And today we're actually going to talk about my friend here. This is a bust of a man who never wrote a single thing. He didn't write any books, he didn't write any papers, he wrote nothing down. He lived in Greece and Athens his entire life. He lived a little bit before Alexander the Great, who came along at about 350 BC. He lived around 400 BC. This is Socrates. Socrates is the father of Western philosophy. He invented philosophy. So what is philosophy? Well, you know, my whole life is on my telephone here, so we just get it out. And there's a dictionary. Philosophy is the rational investigation of the truths and principles of being, knowledge, or conduct. Being, you know, of self-being. Now, there's an outfit that I joined up in Philadelphia called the Philosophical Society. That's actually a scientific society. So the search for truth can be science or it can be anything. Now, how do you search for truth? This is what Socrates taught his pupils. One of his pupils was Plato. And Plato wrote down the dialogues they were having with Socrates on how you find the truth. And it's called the Socratic method. And here's how it works. The CDC announced today there were 70,000 deaths. So you ask a question then to get at the truth. You don't just accept it. You say, who died? Oh, people died of overdoses from opiates. Where were they? So you get to the truth by asking questions. This is what good reporters do. They ask questions. And the more you ask, the more you... Now, this irritates a lot of people because as soon as you start to ask questions, they're saying, well, you're just answering the question with another question. No, this is how you get at the truth. How else would you get at the truth? How do you know when the CDC lies and says there's 70,000 opioid deaths when actually they published an article that said it was only half that in the first place, 17,000, and then they're not telling you who it was that died. Who died? People in the streets. Why are they dying in the streets? Why do people with addiction disease die in the streets? Because they're not treated. We've only treated 20%, and nobody wants to spend any more money on them because they are junkies. And junkies are the worst possible humans in our culture imaginable. If you want to kill somebody, there's an article in here like when they, the Army, what do they do in the Army? They teach people bad words. Gooks in Vietnam. During the Vietnam era, everybody called Vietnamese people gooks. And the Germans were Huns. So by labeling people with something you can focus your hatred on, then you can teach soldiers to do what they really don't like to do, killing other people. Now, in our country, are we killing other people? Yep. We published a long time ago, you can Google it yourself, Google suicide, Google medium suicides, and read about 40 cases. We finally stopped. It got so depressing. When people are taken off their medications, it's so horrible because they have long-term disease, like taking people off their cardiac medicines or pulmonary medicines or insulin. And they finally try for a while as long as they can, and there's no hope of somebody else seeing them, so they just end their lives. That's what's come from this. That's what's come from people failing to ask questions, failing to seek the truth. The CDC's in hot water now because they've got a major medical group, the American Medical Association, saying clearly they have harmed patients. Harmed patients. So, today we want to talk about how to defend yourself when somebody says we're going to taper you. And we're going to do it with words from the CDC. Okay, this is the key thing you need to get. Okay, this is a handbook, pocket guide rather, to tapering and telling doctors how to taper. You can find this because I checked it out. Pocket guide tapering is all you need to put into Google. It's only 4 pages. Print it out. Very important. Okay, up here it makes a statement to doctors now. This is for doctors to read. Follow up regularly with patients to determine whether opioids, opiate pain medicine, are meeting treatment goals and whether opiates can be reduced to lower dosage or discontinued. Now here's the proper doctor way to write this. Follow up regularly with patients to determine whether opioids are meeting treatment goals and decide whether to continue or, if they're not working, discontinue. But you see how they snuck in their bias? Discuss their treatment goals and, gee, Barbara, is it time we taper you off your opioids? And she says, why? Well, you know, you might end up addicted and become a dope fiend and come and kill me. That's what I'm really worried about. But page 2, okay, get this thing off the internet, pocket guide tapering, you'll get it. Page 2 looks like this. And on page 2, consider tapering to a reduced dosage or discontinuing when your patient, okay, it gives 6 reasons, requests a dosage reduction. So your patient comes in and says, I want to take less, fine. Does not have improvement in the pain. Okay. If you're on dosages over 50 milligrams a day, there's that phony thing the AMA wants taken out, without benefits, then you taper. It also says without benefits or opiates are combined with benzodiazepines. I completely disagree with that. But number 4, shows signs of substance abuse disorder. Okay, so if you look like you're addicted, probably you shouldn't be given any more medicine and you should be getting them into treatment. Experiences an overdose or has a serious adverse effect. Of course, we do that for everyone. And lastly, shows early warning signs of overdose risk, confusion, sedation, or slurred speech. So, except for the benzodiazepines, which is incorrect, if you're not on benzos and they're not using that as an excuse, you can say, doctor, which one of these recommended by the CDC are you using to taper me? And do you think it's ethical to taper me without my permission? Because even the CDC says in their guidelines, this must be done with my permission. Where is it in the guidelines? Well, I'll come back and show you, because it's in there. It's in the original CDC guidelines that you work this out with your patient. The rest of this is pretty much useless. Oh no, here's the important one. A decrease of 10% a month, this is on page 3, is a reasonable starting point if patients have taken their opiate pain medicine for more than a year. If you've been on a shorter time, 10% a week. So they're saying don't suddenly taper. And this is the CDC now. Don't taper abruptly. 10% a month if you've been taking it longer than a year. Now, of course, this is all not based on science either, but it's in there. Like the rest of it's not based on science, but it's in there. This is the CDC stuff. Coordinate with specialists, blah, blah, blah. Make sure the patients receive appropriate psychological support. Yeah, it's pretty horrible being tapered off these if you don't need to be tapered. But you see, there's nothing in there that says just taper them. This is all about patient consent and doing it for those 6 reasons that you can make copies of this and take it to your doctor. Now, the other important medical legal issue is it ever appropriate to undertreat somebody? And the answer is no. And here is a little blurb I cut out of the North Carolina Board of Medicine, their policy. The board notes that a failure to provide opioid treatment consistent with the standard of care in North Carolina may subject a licensee, they put this in capital letters, may subject a licensee to disciplinary action by the board. So in my board here in North Carolina, if I were to undertreat somebody and the person complained, I could be subject to disciplinary action. That's really nice. I don't know how many other boards in the country have this, but you can use North Carolina as an example because other boards like to hear, oh, what are they doing? You want to be like the kid next door. So, and are there legal actions you can take? Yes, you can be sued for medical malpractice for undertreatment. If I know that a person needs 500 milligrams a day of tamoxifen to keep their breast cancer under control, and I decide to give them 250, which is not the recommended dose, I just don't want to give as much, that's negligent. Or somebody's supposed to go get 10 radiation treatments, and I say, well, how about 3? That's undertreatment. Undertreatment by us medical professionals is always negligent. I cannot think of an example of purposely undertreating somebody that's sanctioned. Okay, that's medical malpractice. Now, why lawyers don't want to sue? Because all you got to do is mention the word pain and opioids, and you're not going to get any juries or any judges or any lawyers, because 70% of this country believes that junkies are the world's worst people, and it's caused by doctors giving them too many opiates, which we know is not true, or else there would be a lot more of them. If you got 96 million people a year getting opiate prescriptions, short-term, long-term, and you have the same number of addicts, which is about 800,000, do the math. Okay, in the last couple of minutes, we're gonna use Socrates here. Remember this from before? These are the total number of people that have died of opioid overdoses. That's the number of people who have died of opioid overdoses from prescribed drugs by doctors. So we're sending all these doctors to prison because this is how many people die. It's only 500 a year from doctors' opiate prescriptions. Socrates would say, ask more questions. Why is it only 2%? What's the difference? The difference is these are people in the streets that are not treated. All right, last I'm going to show you just quickly some thinking that we're coming up with at JAF about the coronavirus. This is a graph of the virus in Italy. This is a graph of the number of virus cases in the United States. What's the difference? What it is we believe you can fight epidemics, and you can't. This has reached its peak. The virus has run out of hosts. And that's why it's no more there. These last about 6 months like it did last year. In the United States, we haven't gotten to 6 months yet because we haven't peaked. So our prediction is this is going to go up even more. And what you need to do is have the least number of people die. And I'm going to tell you right now that based on the pathology that we've been reviewing, and this is preliminary, little clots are forming, we've said this before, in the blood vessels, and therefore it is my personal recommendation as a physician, and I would do this myself, is to take aspirin, half of an adult or even an adult dose of aspirin, if you have the disease, to prevent those little clots. Preliminary data, we're thinking about it, and we're going to present this soon after we look at more of these graphs. Just to show you another one, that's California. They're not done yet. But when we looked at New York, New Jersey, I don't have them with me, but when we looked at New York and New Jersey in populated areas where there's a lot of density, they all look like it was peaking. It already peaked. So in other words, the coronavirus is different depending on where you are. It's over with in New Jersey, Connecticut, and New York. It's not over with in North Carolina, not over with in the United States as a whole. Thank you, and good evening.